Good morning, everyone. I welcome you all to this instruction course on all about tissue plasminogen activator for retinal diseases. The purpose of this IC is to enable you to understand the functioning of the tissue plasminogen activator, the various logistics of use, the indications of use, and any and every questions regarding to the use as well as the disuse of the tPA will be answered in this IC. So as we all know, tPA is a naturally occurring serine protease produced by a variety of mammalian tissues. The major enzymatic action of tPA is the conversion of plasminogen into a plasmin. That is a broad specificity active serine protease. Now, tPA serves to protect plasmin from antiplasmin inhibitors. Basically, what it does is liquefies the clotted blood. This is the cascade of anticoagulant that it follows. So, what are the commercially available tissue plasminogen activators? Are we okay? So we have alteplase, we have tenecteplase, and we have reteplase. Now there are multiple research papers on use of tissue plasminogen activator in the treatment of vitreoretinal diseases, which would include primarily hemorrhagic conditions, such as these. Now, before we move on to anything else, let's discuss something about the various types of commercially available TPAs. So amongst these are alteplase, tenecteplase, and reteplase. Now, of mention amongst the alteplase, and the most selective and the most resistant to inactivation by plasminogen activator inhibitors. A cheaper commercially available variant of tissue plasminogen activator is the reteplase, which is lesser resistant to the inactivation and has an almost equivalent fibrin selectivity. So it works almost equally as tenecteplase when it comes to the intraocular use. The only advantage of reteplase that we have over here is the commerce of it. It is cheaper than tenecteplase. So if we use a tenecteplase or an alteplase, it would cost you a recurring cost of around 20,000 rupees. But if we use a reteplase with a microdose injector, which is always which is not a reusable one, it's a one-time use, it will cost you around 10,000 rupees. Reteplase comes in 2 vials in one box, and each of the vial is a single use. So in one box you will have a tPA worth of 2 uses. The most common indication of the tPA use is a submacular hemorrhage, and the easiest way to use for a beginner for tissue plasminogen activator is the intravitreal use. It is similar to an intravitreal anti-VEGF injection. So what is the indication for an intravitreal use? Of course, a submacular hemorrhage. Now there is no common consensus on what should be the size of submacular hemorrhage and what should be the size of what should be the duration of the submacular hemorrhage. So based on the study of Dr. Shubhendu Boral, he mentions 3 groups. So in my cohort, my indication of intravitreal use would be a size of submacular hemorrhage worth 1 to 3 disc diameters with less than or equal to 7 days old history, in conjunction of course with a pneumatic displacement. Now what should be the dose of intravitreal tPA? Somewhere around 25 to 100. Now some papers say that above 50 micrograms is toxic. Some papers say that 100 micrograms is also well tolerable. So for the purpose of this IC, we would mention the safe dose to be around 25 to 100 micrograms per 0.1 ml. Now what is the rationale of an intravitreal use? It increases the chances at resolution by inducing clot dissolution. Now let's look at how does it work. So this is a very good paper on analysis of forces acting upon submacular hemorrhage and pneumatic displacement. What this paper shows is that the clotted blood displaces the vitreous and as a result there is a Bowen force acting on it, which is nullified by the gravitational force acting on the hemorrhage. So the Bowen force and the gravitational force, they cancel each other out, and as a result the blood clot does not move. So to make sure that the buoyancy is lesser than the gravity, the type of substance that gets displaced by the volume of the submacular bleed should be lighter. And there is where the role of pneumatic displacement comes, wherein you replace the fluid interface with the gas interface, and as a result the buoyant force reduces and the gravitational force overpowers and the blood settles down. Now that is the reason of a particular type of head positioning that we have to adopt in case we are not vitrectomizing the eye, but we are just partially filling the eye with air. The position has to be such that the blood clot comes in contact with the gas. Now, complex mathematical equations and cosine functions lead us to calculate that the least amount of gas that is recommended is 60% fill in a straightforward looking eye. And without vitrectomy, if C3F8 is used, the gas would expand to 1.6 ml. The patient's gaze would need to be positioned at an angle of 40 degrees below the horizontal plane. Now, the prerequisite of all of this is a non-adherent mobile liquefied clot, and that is where the role of tissue plasminogen activator comes in, wherein the clot mobility and adhesion prevention and clot liquefaction is induced, and also the liquefied blood is slightly of greater density than the intraocular fluid. Because of all of this, in presence of a gas bubble, the gravitational force overpowers the buoyancy force and we have a gas displacement. So a case to illustrate this: a 75-year-old one-eyed male had no systemic illness and had diminished vision in the right eye since 13 days. Now this was the clinical picture. The patient had a massive submacular bleed, and this was the OCT. It was secondary to PCV. So the plan was intravitreal tissue plasminogen activator with brolucizumab with C3F8 gas and relay, followed by 2 monthly intravitreal brolucizumab under tPA. So this was after the first injection. There was near complete clearance of blood because of the tPA and pneumatic displacement, and this is after third dose, and the vision improved from a 1/60 to a 6/9 parts. And this was the clinical picture at the end of the treatment. Now, a simpler route of administration is intravitreal, but the outcome is unpredictable due to multifactorial causes. Intravitreal route has been debatable because of the doubts of its penetration through the internal limiting membrane. There are certain studies which says, like a study by Kami et al., which says that the penetration is not there, so intravitreal route is not useful. But again, there is a paper by a scientist named Colley which says that the albumin, it diffused, which is of almost a 68 kilodalton protein, it diffused through the ILM, and the tPA is around about the same mass. Then there was another study that showed a diffusion of fluorescein isothiocyanate in the rabbit models. Unfortunately, there has been no human study, to the best of my knowledge, which objectively demonstrates whether the tPA passes through the ILM or not. So it still remains a topic of debate. Now that this brings us to the question, what should be the timing and what should be the indication of an intravitreal tPA, if at all we have to take a chance with it. So as we all know, 14-day mark is when the visual, the clot starts to form a recalcitrant version of it. So usually my indication is round about, if the clot is less than 7 days old and if the clot is less than 3 disc diameters, we can always take a trial of pneumatic displacement with tPA and follow it up in 1 week's time. If in 1 week's time, that is at the 14th day mark, if there is no resolution or no desired resolution of submacular bleed, we can go in for the subretinal route of administration, which will be further discussed by Dr. Anirudh Maiti. So please.
लोड किया हुआ है अनिरुद्ध. Very good morning. At the outset, I would like to thank Vibhuti for this opportunity. Well, I will skip this session. We are all aware of the indication for this tPA, intravitreal or subretinal, that is submacular hemorrhage, and mostly it is PCV. What is important is we need to distinguish between the subretinal location or the sub-RP location, because the treatment varies according to the location of the hemorrhage. Now, there are various modalities of treatment as mentioned by Vibhuti, like anti-VEGF, pneumatic displacement with anti-VEGF, intravitreal tPA with anti-VEGF and pneumatic displacement, and subretinal injection of tPA. Anti-VEGF, yes, if the submacular hemorrhage is thinner, that is less than 400 or 450 microns, and the if the indication is for CNVM, or already there is a scar, so we have some time, because in these cases we need to resolve the blood as soon as possible. But if the prognosis is not that great and hemorrhage is not very large and the submacular hemorrhage is thinner, then we can try with anti-VEGF, as in this case from finger counting 2 feet to 660 vision, you can see the central CNVM scar. Now, there are certain submacular hemorrhage as a ram bleeding. We had given a pneumatic displacement with anti-VEGF, and which resulted in a breakthrough bleeding, which happens sometimes, and we need to tell about this beforehand to the patients. I'll just forward this. Forward nahi hoga. So this was a breakthrough bleeding, and thoda forward kar dena. Or. So once we get rid of this dense hemorrhage, we can actually see the amount of bleeding, the subretinal bleeding has reduced, and we can identify the area of the ram. Or thoda, it should have a control from here. Last में चला जाइए. Yeah, now we can see that the area of the ram, and this patient eventually had a very good outcome. As you can see, after almost 2 weeks, the vision improved to 612, and you can see a very nice macula. Now, Vibhuti was discussing in which cases we give the intravitreal tPA. This was the hemorrhage was definitely more than 4 disc diameter, but it was a thinner, and we tried with the intravitreal RTPA. In fact, there are studies which say that it gives an equivalent result as well. So you can see it is a very typical PCV bleed with a multiple PED and notched PED, and it actually gave a pretty good results. This is the picture after 3 weeks. This is 2 months, and after 3 months, we gave a loading dose as well after the intravitreal tPA and intravitreal injection, and at 3 months it was 6.6. Yes, now in which cases we will give the subretinal RTPA with anti-VEGF and pneumatic displacement when the thickness of blood is more than 450 microns and more than 4 disc diameter. In those cases, we have to give subretinal RTPA, as in this case. Forward करना है. Forward करके ही दिखा दीजिए. So we are inducing PVD. You can see the hemorrhage is pretty fresh, and it's a huge one. We had given in the multiple paces TPA, and it responded pretty well. The only thing is we need to keep in mind that it should not be very close to the posterior pole, otherwise we might result in a iatrogenic macular hole. Another indication, this was a breakthrough hemorrhage. After removing that clotted blood, we could see the subretinal hemorrhage partially clotted as well. And after removing the entire bleeding, we had given subretinal RTPA. थोड़ा फॉरवर्ड कर दीजिए. बस यही This is good. So once we remove all the blood, and as you can see, the thickness of blood was not that great in the posterior pole we had given in the near the arcades, and this patient also responded pretty well. Coming to the last case, generally the algorithm is you should treat within 2 weeks preferably, but this was a case which came pretty late, almost a month after, and as you can see, the hemorrhage has clotted to the major extent, but the patient was very keen that something needs to be done. So we proceeded with this case with the subretinal RTPA. The ones doing the PVD, and in this case we had to do in a posterior pole. As you can see, we thought we have created an iatrogenic macular hole because there was no option of giving the intravitreal tPA in other places. So, but to our surprise, it actually didn't cause any macular hole, at least in the postoperative period, immediate postoperative period. In fact, with time, there was improvement to finger counting, 5 feet, but after 3 months, when the total blood has resolved, there was a macular hole formation, as expected, and it happens when we are injecting too close to the macula, this RTPA. So we did an macular hole surgery for this patient, and obviously it was a large hole, so we did an inverse peel technique. And luckily this patient, the macular hole was closed, the hemorrhage was not there, and at least we could give an ambulatory vision from finger counting to 660. So we need to, the most important part, we need to address the underlying pathology, whether it's a RAM, we need to do a laser, CNVM anti-VEGF, the PCV, either monotherapy or combination with the PDT, or extrafoveal we can do some lasers. So overall, it's a very challenging situation, some macular hemorrhage, but if we can treat based on the algorithm, we can actually give a reasonably good visual outcome if it is treated in the right time. Thank you. Yes. Yeah, the 4 we didn't know about the extent of the hemorrhage because it was a breakthrough hemorrhage. We had planned for subretinal people. You are absolutely right. If it was like if there was no breakthrough hemorrhage, we might not have given the tPA because the central part was thin. So that the only reason I had given because there was a breakthrough hemorrhage, and this last case there was a clotted blood, which. Yeah, it was finger counting 1 feet or 2 feet, and it improved to 660. Yes, we didn't expect much improvement because it presented pretty late and the blood was also clotted. But the patient was very keen that something needs to be done, so that is the reason we proceeded. Uh, didn't face such a situation, but generally that case was a very atypical one because generally we can see the hemorrhage and then plan the RTPA, and in this case we could not do that because there was the full of hemorrhage was there, the breakthrough hemorrhage was there. Yeah. And I think we don't use that much of intravitreal RTPA, which is actually very useful at times. The case I had shown, it improved significantly. Well, from 660, it was 66. And seeing the hemorrhage, we had, according to the algorithm, it is actually, we need to do an RTPA, but intravitreal RTPA worked pretty well in that case. It was a fresh one. Yeah. But in the clotted blood also we can give a try. At least we can restore. Yeah, yeah, true. Complete. Gas. Gas. It works.
Right. Thank you, Anuradh sir,
Thank
for
you.
a wonderful talk. I would like to now invite Dr. Sangeet Mittal sir for his talk on delivering subretinal tPA my way, a self-designed subretinal injector.
So good morning, everyone. Can I have my slides, please? Thank you. So I'll be continuing on where Vibhuti and Dr. Anirudh had left, and where when and how I use it, the TPA. So I'll just this is the and TPA can be used in an intravitreal, subretinal, or suprachoroidal. They have been reported like this. And when I use it in small submacular hemorrhages, I give intravitreal. In large submacular hemorrhages, I give a subretinal. In hemorrhagic retinal detachments, again varies. Then suprachoroidal hemorrhage and subsilicon oil pre-retinal hemorrhages we have tried, but I'll discuss about it. So this technique, in small displacement using intravitreal gas and tPA, this technique attempts to physically displace the submacular hemorrhage out of the fovea using an expansile gas, faster by liquefaction of the clotted blood using tPA 50 micrograms. The procedure is performed under topical anesthesia and involves an intravitreal injection of 0.3 to 0.4 ml of SF6 or C3F8 gas and face down positioning for 1 to 3 days. And so the advantage is that it's an office procedure and the displacement time is short, but can be done only if the hemorrhage is small. Otherwise, it doesn't work. So this is an example of a macroaneurysm resulting in a submacular hemorrhage. And in this case, you see most of the blood is pre-retinal, some of it is subretinal. We just give an intravitreal TPA and give the prone positioning, and this is post-operative. You see the hemorrhage has displaced nicely with the intravitreal TPA alone. And here this is another patient presented with hemorrhagic retinal detachment. Again, an intravitreal TPA was done, but we did an external drainage in this patient. So these are two indications where I generally use intravitreal TPA. In this case, subretinal TPA won't work much because there was so much of blood. So we give intravitreal TPA 1 to 2 days before we plan the patient for surgery. The injection was given, the clot reduced in size, and 2 days later we took up the patient for the surgery. We drained the blood externally, and this is post-op, 1 week post-op, and you see a lot of clearance of the blood in this eye. So for subretinal TPA, we generally use the small 41 gauge or 40 gauge or 38 gauge microcannulas to inject TPA. And this is a small video.
A small hole is made into the rubber of a 10 ml syringe. The cut tuberculin syringe is then fitted into the rubber. A hole is then drilled in the 10 milliliter syringe and its hub is removed. Tuberculin syringe prepared earlier is then fitted in this 10 ml syringe as shown. This apparatus is then connected to the VFI system on vitrectomy machine. The drug is filled into the syringe from top and microcannula is connected. The speed of the injection can be foot controlled.
So although nowadays commercially available subretinal injectors are available, but I used to do it before those injectors were not very commonly available, and this is one technique that you can make your injectors itself in the operating room. So if you don't have the subretinal injector available with you, you can use this simple technique to make this homemade injector and use it. I had to do it because earlier what we used to do was like an assistant used to inject while we used to hold, and the pressure, how much to inject, the assistant won't be able to gauge properly, and many times the macular blowout, as shown by Dr. Anirudh, happened sometimes. So in those cases, then we had to design something that properly foot controlled or properly controlled injection is done. So we had to make this kind of injector, and using of injector is important in these eyes. So this is another video showing the subretinal tPA injection.
An 85-year male presented with complaints of sudden decrease of vision for 10 days. He was diagnosed as massive subretinal hemorrhage secondary to IPCV. Incidentally, he had undergone retinal surgery for vitreous hemorrhage, retinal detachment and subretinal hemorrhage in other eye too about 3 months ago. We plan to do vitrectomy with subretinal injection of tPA in this eye. After completing vitrectomy without base excision, ICG-assisted ILM peeling was done.
I use ICG in these cases because there is a poor contrast. So if I have to peel an ILM, I use ICG rather than a brilliant blue in
tPA
these
in the
eyes.
dose of 25 micrograms and 0.1 ml was injected subretinal using a 41 gauge micro cannula. Subretinal bleb was raised slowly with the help of a self-made subretinal fluid injector. The injection was done at 2 different sites. Fluid air exchange was done. 20% SF6 gas was used as tamponade. Patient was advised prone positioning postoperatively. 3 weeks post-op, significant reduction in subretinal hemorrhage was seen. 6 weeks post-op, subretinal hemorrhage had resolved and visual acuity improved to 6/9.
So the results are quite gratifying, and I'll just show you one more last technique how to do it. This is use of subretinal air with tPA. So this was a patient. You have to, when you're using air, you inject inferiorly. So when you inject inferiorly, the air bubble that you inject, it displaces to the inferior quadrant. Otherwise, it will go superiorly and cause problems. So here you see the air bubble going inferiorly. And now you inject tPA. Maybe you can use the same location or you can use a different location to inject the tPA. And once the bleb is raised, then you do a partial fluid air exchange in these cases. And what happens is when you make and ask the patient to sit down postoperatively. So when you ask the patient to sit down, the upper half will be covered by air, and the air bubble which has gone displaced inferiorly comes to lie in the macular area. And that air and the tPA which has now lies the blood will help the blood to move down, and then you close the case. You may use SF6 or leave it on simple air also. So here I'm using SF6 in a partially air-filled eye, and you see this is 1 week post-op. The blood has been displaced and the patient's vision has improved to 6/24. And this is like 6 weeks post-op again. The patient's vision had improved to 6/9. So you can use it in suprachoroidal hemorrhages. This is suprachoroidal tPA was given 24 hours prior to surgery to lyse the blood. And this was a patient who had a giant retinal tear and
was placed inside the cannula.
suprachoroidal hemorrhage.
Indicated correct placement of cannula in the vitreous cavity. 4-port vitrectomy with chandelier in infranasal quadrant was started and anterior vitreous was removed. Retina was seen in the iris plane. Supratemporal cannula was seen to be in suprachoroidal space. Tissue surrounding the cannula was dissected to bring it in vitreous cavity. Vitreous adhesions to iris were removed and anterior vitrectomy completed. Core vitreous was removed to reveal the posterior hyaloid. Triamcinolone assisted induction of PVD was done and vitrectomy with base excision was completed. Subretinal blood was slowly aspirated using silicone tip back flush cannula.
This is the last video.
Remnants of capsule were peeled and removed. PFCL was used to stabilize posterior retina and ILM was peeled under PFCL. Subretinal bands were peeled to take care of fixed folds. 26 gauge intravenous catheter was inserted in suprachoroidal space to remove the residual hemorrhage. After confirming the tip to be in right place, the metallic stellate was removed, leaving the plastic cannula behind, and blood was drained out.
So you see, because of the tPA that we had given, the blood was lysed, and you can easily remove the suprachoroidal hemorrhage also. So this is post-operative. I thank you for using it. We have used in pre-retinal hemorrhages of silicone oil, but the results have not been that great. Thank you.
Thank you, sir. Now I'll invite the next talk, Dr. Devesh Kumawat, for his talk on my journey of tPA use, beginner's block, initial concerns, and subsequent experiences.
At the outset, I would like to thank Dr. Vibhuti for including me in this important IC.
Dr. Sangeet Mittal, sir, if you can please come on.
So, in the meantime, while my slides are being ready, Dr. Sangeet, I have a question for you. So, I have used it in one case of suprachoroidal hemorrhage, and at the time of drainage only, I had injected tPA because there was partial drainage, and to my surprise, there was a rebleed that happened. So, does it increase the risk of rebleeds also? So the next day there was a rebleed again. So I don't know whether it was because of the tPA injection or because it lyses the clot and you can have secondary hemorrhages.
The effect of tPA is just to lyse the clot. I don't think that it acts as an anticoagulant or something like that.
Okay, but the secondary hemorrhages generally happen because of the clot movement or clot retraction.
Yeah, that may be true, that because there must be massive clots. So if you have to inject suprachoroidal, then you have to do multiple drainage sites. Then only you will be possible to remove whole of the blood. I think maybe because of the injection that you had given, maybe you had given it one place or?
I had given it one place.
One place. So maybe the clot had not lysed in some other place, which had lysed later on and then resulted in that hemorrhage.
So I'll be talking about my journey of tPA use. So overall, if I want to summarize it in the beginning, only in which all cases I use and what is my approach. So it depends on the size. Like if it is less than 4 disc diameter, I also use intravitreal tPA and pneumatic displacement. And if it is more than 4 disc diameter, I go with pars plana vitrectomy. In addition to that, if the thickness of the subretinal bleed is more than the submacular thickness, provided it is in the center of the fovea. So then also if the size is less than 4 disc diameter, then also I sometimes consider PPV and subretinal injection in those cases. Now duration, if the color is bright or dark red, then I consider it, and if it is gray, then I don't, and I explain the prognosis. And so this was my first case that I had done. It was a 10-year-old male boy with aplastic anemia with diminution of vision, and the right eye of the patient had diminution of vision for past 3 months. And there was dense vitreous hemorrhage, and the ultrasound showed subretinal echoes as well, dot echoes suggestive of subretinal hemorrhage. And the left eye had multi-layered hemorrhages. We took the patient for right eye vitrectomy, and submacular tPA was injected in this patient. So 25 gauge vitrectomy was taken, was performed, and after doing the core vitrectomy, we can see there are multi-layered hemorrhages, pre-retinal as well as intraretinal and subretinal. And there was a thick sheet epiretinal membrane at the macula, so that was peeled. ILM was also peeled in addition to that. Generally, I don't do ILM peeling, but there was a thick epiretinal membrane, that's why it was done. Now, using a 41 gauge needle, and I do prefer manual injection over here, and I choose usually 2 sites, one superior and one inferior to the foveal area. And over here, subretinal air was also injected, and we can see that the air is dissected into the inferior periphery, and there was a foveal blowout as well. So this was my first case itself in which there was a foveal blowout, and then I did a fluid air exchange and left it in under 20% SF6. So this is at 3 weeks post-op. The retina was well attached. The submacular bleed has partially displayed, and at 6 weeks the vision has improved to 4/60, which was better than the pre-op vision, and the child was ambulatory. And this is the OCT at 6 weeks, which shows that outer retinal layers, although they are attenuated, but still the foveal contour is well maintained. Now, following that, I've been working at AIMS New Delhi, and we have the compounding pharmacy available at RP Center. So it is usually altiplase that we are using in form of aliquates. They are compounded in the pharmacy, and they are stored, and whenever we want to use, we can ask from the pharmacy. So this is a case of 61-year-old male patient with hypertension, diminution of vision for 2 weeks. Mind you, all our patients, mostly they usually present after a week, so they are relatively old, and still we do try in them unless the hemorrhage is grey that I told, or it is very old. So over here in the OCT is very important in identifying the exact location of bleed, because sometimes you can have massive sub-RP mounts as well, and intraoperatively you need to be in the subretinal space and not in the sub-RP space, because otherwise you will not be able to inject in sub-RP space. So the fluorescent angiography shows that it was a ruptured ram with the vascular occlusion in the supratemporal quadrant. 25 gauge vitrectomy was performed. PVD was induced. Oh, sorry. It's not playing. Okay. Moves in the mid periphery. Once you do the fluid exchange, it tends to come back to the posterior pole. And in the early post-op period, I usually advise the patient to take propped up position, prone position for an hour, and then take up propped up position for the next 1 week. At post-op 1 month in this patient, the BCVA although did not improve because there was foveal atrophy and extensive ischemia was there, but the anatomical results were gratifying. In the case 3, it's a wet AMD related submacular bleed of 3 weeks duration. Now we can see that the diminution of vision is for 3 weeks. The hemorrhage still appears relatively fresh. So we took up the patient for surgery, and here again intravitreal subretinal tPA as well as Avastin and air injection were performed. And the difficulties that I've faced with manual injection is only with when I'm using air. If I'm not using air, then usually it is a smooth process which happens, and I've not faced any difficulties in injection manually. So at 3 weeks, the bleed had significantly displaced the sub-RP, the CNVM complex is still there, and the patient was further treated with anti-VEGF injections. This is the last case, again a case of the video is not running. It's not playing. So okay, so I usually assess the need for subretinal submacular injection based on the size, thickness, and duration, as I told. And preoperative planning with OCT is very important, because you want to know the location of submacular bleed, which may not always be very obvious intraoperatively, and you need to know that you are not in the sub-RP space. And you can use you can reconstitute, or if you have the facility compound as we have, you can use compounded tPA as well. Augmentation with air, I have now switched to not using air, intravitreal subretinal air, and I see that my results are equally good. And the additional risk that is there of the foveal blowout is with the air. My only 2 cases in which the foveal blowout happened was with air, because with manual injection it is difficult to control the injection of air. You have that resistance, and then there is a give way, which may not happen with the micro injector. So if you are doing it manually, then I would suggest doing it without subretinal air. Thank you.
Thank you so much, Dr. Devesh. Now, I'll move forward with the last talk, and then we can have the discussions on the talks.
So while you get ready, I just, so one thing is like about the foveal blowout. If you inject inferior to the arcades, then the chances are again very less of the foveal blowout. If you inject superior, then the chances are more. So that is one thing for there. You can use, sometimes we have to use air in, because sometimes these patients are very old and they can't lie prone post-operatively. In those cases where you have to give a propped up position, then you may need some subretinal air in those cases.
Duplicate slide. So coming to the last talk of this IC, some of the non-hemorrhagic, non-conventional uses of tissue plasminogen activator. So the potential indications, there are no randomized controlled trials, there are no studies of good relevant power to showcase all of this. These are just case reports which have a further scope of research into it, and probably institutional practitioners like Dr. Devesh uh, may pursue this if it interests you. So potential indications are epiretinal membranes 24 to 72 hours prior to vitrectomy for ERM peeling, and a focal vitreomacular traction. The dose is similar to the intravitreal use of tPA. The rationale is the loosening of the adhesion of epiretinal membrane and vitreomacular traction adhesion at the vitreoretinal interface. Now, where does this come from? So the vitreoretinal interface, when we look at the protein analysis of it, it is made up usually of collagen 2 and 9, fibronectin and laminin. Now, if we refer to this study done primarily in a nephrology setup, this actually analyzed the use of plasminogen activator inhibitors in kidney diseases, where the remodeling, the broad serine protease activity of plasmin was taken into account, and said that because plasminogen activator inhibitors are found in high numbers, there is no remodeling, and as a result there is consequent kidney fibrosis. So plasmin may be needed for prevention of fibrosis, because not only fibrin, it modulates the other proteins as well. So this was what it postulated, that plasmin is not only for degradation of fibrin, but it also degrades fibronectin, laminin, proteoglycans, and type 4 collagen, and type 2 and type 9 collagens as well. So this was one of my cases where I used this. Of course, there was no objective way of deciding how adherent this ERM was. Clinically, this was a grade 2 ERM in a post vasculitis patient. It had a broad adhesion and looked very tight. So in this patient, we injected the tPA 48 hours before surgery, and during surgery, the peel was very smooth without adhesions, which made us to think like tPA may act like alcohol for how alcohol acts for epithelium in a case of PRK, tPA can act for ERM in a case of peeling. So this is how simple it was. It showed no resistance during peeling, and it just lifted up because of probably proteolysis at the vitreoretinal interface. Now this is second case of vitreomacular traction, focal traction. The patient was not willing for surgery, and as a result, we used tissue plasminogen activator with due explained prognosis and chances of recovery. We told the patient this is not a very known treatment, and if you want, we can give you a trial of. And yes, there was no pneumatic injection that was tried in this. Only tissue plasminogen activator, and the vitreomacular traction relieved with a symptomatic improvement of vision from 4/60 to 6/36. So these are my two indications, two non-conventional indications, non-hemorrhagic indications of tPA use, which has the potential of future research and bigger cohort of patients with these indications. Thank you. We can now please move on to the panel discussion and continue it if anybody has any queries. Yeah, it may. That is what my point of this presentation was, that the vitreomacular interface surgeries may become simpler. There will be less amount of traction, but then the study design has to be such that we need to also judge the retinal toxicity. What is the dose that is required for that kind of proteolytic activity? What is the duration for which you have to leave, even if it's a higher dose which causes retinal toxicity? Then for how long does that need to be left at that place, I mean intravitreally, for it to cause the proteolysis and as well as not cause the toxicity? Then we have to also have control groups. The ease of peeling has to be, it's very subjective. There has to be a reasonably objective way of saying that yes, the traction is less, or there has to be a reasonably objective subjective way of saying if the peel is okay. But this is my personal experience. I have not read this. I was just going through this paper for one of my relatives, and I came across this, and that was where serendipity happened. I didn't plan to do this, but when I saw this, I felt like interface can be loosened, so it may act like, as I said, alcohol in PRK for epithelium. PVD. Yeah. Yes. Absolutely. Yes. ROP. Yeah. Sir.
I'm not sure because all these things they will always have a double edge.
That is why I said it's for people with institutional practice.
Yeah. Yeah. Yes. Initially, we did not plan to do a vitrectomy. Yeah, and I thought I'll just inject tPA and do the external drainage, and then see how the patient behaves. So I had to do a vitrectomy because there was an inadvertent break that happened, and that's why I had to do a vitrectomy and put in oil and just get. Yeah.
Alright, so this brings us to the end of this instruction course, and I thank everyone for joining us, and we hope to see you next year too. Thank you.